Morning, one and all. So, I'm Dr. Merwin Paul, Assistant Professor, Department of ENT, Sri Lakshmi Narayana Institute of Medical Sciences. So, yes, so we'll discuss about tonsillitis today. So, tonsils are basically a pair of lymphoid organs. So, there are various types of tonsils which is present in the head and neck region. So, the main tonsil is the palatine tonsil, so which we have it in the oropharynx. So first we'll discuss about the anatomy of the palatine tonsils. So palatine tonsils are a pair of ovoid structures which is present between the anterior and the posterior pillar, which is in the oropharynx. So the anterior pillar is basically the palatoglossus, and the posterior pillar is basically the palatopharyngeus muscle. Okay, so tonsils are basically situated in between the two pillars. So yes, so the tonsil, it has two surfaces. So there are two surfaces and there are two poles for tonsils. So usually the surfaces are the medial and the lateral surface, and there are two poles. One is the upper pole, the other one is the lower pole. So the medial surface of the tonsil is covered by non-keratinizing stratified squamous epithelium, and there are 12 to 15 crypts on the medial surface. The largest crypt is called the crypta magna, or the intratonsillar cleft, basically. So yes, so this is the tonsil structures. This is the tonsil basically. So here you have the medial surface, and this is the lateral surface. And in the medial surface, like they said, you have crypts, which is present in the medial surface. So there are about 12 to 15 crypts in the medial surface, and the largest one usually which comes in the center, that's the crypta magna. Okay, so yes, so what are these crypts? Usually they check on the any particle which enters the oropharynx. So they check on, it's like a it keeps a check on the microorganisms which enters. So if the tonsils find anything which is not good for the body, so they'll start the immune response. Okay, so yes, so the lateral surface of the tonsil presents a well-defined fibrous capsule. So it has got a covering, which is the fibrous capsule, and loose areolar tissue lies between the tonsillar bed and the capsule. It is the site for collection of pus in peritonsillar abscess, which is otherwise known as the quinsy. So yes, so the tonsil is well placed in a bed that's called the tonsillar bed. So the tonsil has a covering. So lateral surface is actually covered with a tonsillar capsule. So the tonsil is placed in the tonsillar bed, right? So it between the tonsillar bed and the lateral surface, you have this loose areolar tissue, which is there. And the upper pole of the tonsil extends into the soft palate. Its medial surface is covered by semilunar fold called the plica semilunaris. So the lower pole of the tonsil is attached to the tongue. So there is a triangular fold of mucous membrane extends from the anterior pillar to antero-inferior part of the tonsil, enclosing the plica triangularis. So the upper pole has plica semilunaris, and the lower pole has plica triangularis. So the tonsil is basically, so the tonsil, like I said, it's placed in the between the anterior and the posterior pillar. So anteriorly you have the tongue. So the tonsil has to be separated from the tongue, right? So yes, so they have tonsillolingual sulcus, which separates the tonsil from the tongue. So they have this crypta magna. So the largest crypt in the tonsil is called the crypta magna. So tonsillar bed. So basically, uh, so the tonsillar bed is formed by certain structures. So this is very important, because, like I said, between the tonsil and the tonsillar bed, you have a space that's filled by loose areolar tissue where there is pus collection. So which leads to quinsy. So the tonsillar bed has to be taken care when you're doing a surgery. So what happens? You have to, these are all the vital structures which is present in the tonsillar bed. So you have to really be careful when you're doing a tonsillectomy. Okay, so tonsillar bed, it is formed by first, like I said, so after the capsule, you have the loose areolar tissue, which has this paratonsillar vein, which is the most common bleeding vein in tonsil during surgery. And then you have the pharyngobasilar fascia, and then you have the superior constrictor muscle, and then you have the buccopharyngeal fascia, then you have the styloglossus muscle, then you have the medial pterygoid muscle, then you have the glossopharyngeal nerve, and then the facial artery, the submandibular gland, and the angle of the mandible. So these are the structures which forms the tonsillar bed. Okay, so now moving on to the blood supply of the tonsil. So, usually the main supply of blood supply is from the external carotid artery and its branches, basically. Okay, so there's a mnemonic. So it's T double A double D. So TAD, T double A double D. So that is tonsillar artery, ascending palatine artery, ascending pharyngeal artery, descending palatine artery, and dorsal lingual branches. So these are the blood supply of the tonsil. So the tonsillar artery is basically, so like I said, starts with T, tonsillar artery. So tonsillar artery, it is a branch from the facial artery, basically. And then I said ascending palatine, which is also a branch from the facial artery. Then you have the ascending pharyngeal artery. So basically, it's a direct branch from the carotid artery. So it's a branch. So the tonsillar branch of the ascending pharyngeal artery. And then D. So one is the descending palatine artery, which is a branch of the maxillary artery. And then you have the dorsal lingual branches. So that is from the lingual artery. So this is the basic blood supply of the tonsil. And the venous drainage, it follows the artery, and you have the paratonsillar veins also. So lymphatic drainage. So the lymphatics pierce the superior constrictor and drain into upper deep cervical, that is the jugulodigastric node. So usually when there is a tonsillitis, so the patient comes with a complaint of tonsillitis, you palpate the jugulodigastric node, so which is usually enlarged and tender in a case of acute case, and enlarged non-tender in a case of chronic tonsillitis. So the functions of the tonsil. So yes, so like I told you before in the beginning of the class, like when I started with the anatomy, so it just keeps a checklist of whatever that is entering into the oropharynx, right? So basically functions of the tonsil. So it is a component of the inner Walde's ring. Okay, so the Walde's ring, basically it consists of all the lymphatic organs. So that is the palatine tonsil, nasopharyngeal tonsil, otherwise called as the adenoid, the lingual tonsil, the tubal tonsil, the lateral pharyngeal band. So these are the components of a inner Walde's ring. So the tonsil, it has a protective role and act as a sentinel at portal of air and food passage. So Sentinel, something which comes in contact for the first time. So whatever that is entering, so be it the air or the food that is entering, so it just keeps a checklist, like if there is any microorganism or something which is not good for the body, it just keeps a check. And the crypts increase the surface area for contact with the foreign substances. So I said there are 12 to 15 crypts on the medial surface of the tonsil. So why is that crypts? Why are the crypts present? Why should there even be crypts in the medial surface? Because it increases the surface area, so that the contact of the foreign substance, that is the food, be it air, so it just has a bigger surface area, so that whatever that is entering has a contact with the tonsil. Okay, so there are two types of. So this is about tonsil. So this is the normal anatomy and the functions of the tonsil. So let's go to the pathology. So what happens to the tonsil in case of a disease? So what are the diseases that can occur in tonsil? So basically, it's the tonsillitis. So that is the inflammation of the tonsil, basically. So there are two types. Usually, any inflammation, it could be acute or chronic. So there are two types of inflammation that can occur in the tonsil. So first, we'll talk about the acute tonsillitis. So it mostly affects the children in the age group of 5 to 15 years. It can also affect the adults. Okay, so children, it is one of the primary um, lymphoidal organs. So that keeps because the immunity of the children is not very well developed. So these are the lymphoid organs which take care of it in children, basically. So the organisms which is the beta hemolytic streptococci. Most commonly, it's the group B, and the staphylococci and pneumococci and Haemophilus influenza. So for a acute case, so what are the symptoms that the patient can present with? So usually the patient will come with complaints of sore throat, difficulty in swallowing, difficulty in breathing sometimes, fever because there is an acute inflammation, and earache, and other constitutional symptoms such as diarrhea, vomiting, anything can happen. So basically, it's the sore throat that the patient will come with the complaint, and difficulty in swallowing, definitely. So in acute tonsillitis, you have various types of acute tonsillitis. So there are basically the four types. The one is the acute catarrhal or the acute superficial tonsillitis, and the other one is the acute follicular tonsillitis. The other one is the acute parenchymatous tonsillitis, and the other one is the acute membranous tonsillitis. So acute catarrhal or acute superficial tonsillitis. Here, the tonsillitis is a part of generalized pharyngitis, mostly seen in viral infection. So, like I said, the common organisms usually are the beta hemolytic streptococci group B and staphylococci, pneumococci, Haemophilus influenza. So here, the acute catarrhal or the acute superficial tonsillitis. Here, the tonsillitis is a part of general pharyngitis. The patient has pharyngitis, so along with the pharyngitis, the tonsil is also involved. So it's mostly seen in the viral cases, basically. And there's something called the acute follicular tonsillitis. Here you have some kind of a follicular appearance. So infection spread into the crypts with purulent material presenting at the opening of the crypts as yellow spots. So like I said, in the medial surface, you have 12 to 15 crypts. So the infection gets into this crypts. So this 12 to 15 crypts, it has an opening, right? So it presents as a purulent material, which are spotted as a yellow spots. So that's why it's follicular. It looks dotted. It has a dotted appearance like a follicles. So that's why it's called the acute follicular tonsillitis. Then acute parenchymatous tonsillitis. So this is nothing but the whole of the parenchyma of the tonsil is involved. The tonsil is enlarged in such a way that the whole of the tonsillar parenchyma is infected. The tonsil is uniformly enlarged and congested. So when you see the patient with an acute parenchymatous tonsillitis, you see a enlargement of the tonsil, which is uniformly enlarged, and there is congestion that you can see. And there's something called the acute membranous tonsillitis. So it follows the stage of an acute follicular tonsillitis. So here, like I said, you have yellow dots which is present in the tonsil. So here, all these yellow dots join together to form like a membrane, basically. So acute membranous tonsillitis, it follows the stage of an acute follicular tonsillitis, where the exudates coalesce to form a membrane on the surface. So all these dots, which is present in the acute follicular tonsillitis, it joins together to form a membrane on the surface. So basically on the medial surface, which is the surface that you can see. Okay, so this is the picture of an acute catarrhal or superficial tonsillitis. So the tonsil is inflamed. Along with that, it's pharyngitis. So acute follicular tonsillitis. Here you see some yellow dots or spots. So this is the looks like a follicle. So these are the scripts which is present in the tonsil, and you can see the yellow purulent material which is coming out. Okay, there's something called the Merwin move sign. So when you press in the anterior pillar, so the cheesy material will just come out. That's called the Merwin move sign. Okay, membranous, acute membranous tonsillitis. So all these dots in the acute follicular tonsillitis, it is joining together to form a membrane-like thing. So it's the acute membranous tonsillitis. Okay, so like I said earlier, so the patient will come with complaints. So those are the symptoms that the patient will give. So what are the symptoms? Basically, it's the sore throat, fever, difficulty in swallowing, difficulty in breathing. So these are the symptoms that the patient will come to you with. So the signs. So what you elicit from the patient. So you examine the patient. So when you're examining the patient, you get a halitosis. That is the bad breath that you get from the patient. So when you ask the patient to open his mouth to see his tonsils, you get a bad breath. That's the halitosis. And otherwise, you have this coated tongue. When you see the tongue is coated. And the congestion of the pillars, soft palate, and the uvula. So since there is an inflammation, it's an acute inflammation, you see congestion, congestion of the pillars and the soft palate, which is above and along with the uvula. And the jugulo-digastric node. So we discussed earlier. So tonsils drain into the jugulo-digastric lymph node. And so what happens, since it's an acute case, so the jugulo-digastric nodes are enlarged, and as well as it is tender, basically. Okay, so the tonsils. So the tonsils are congested and enlarged depending on the type of the acute tonsillitis. So when you look at the tonsils, so the tonsils are definitely congested because there is an inflammation, and enlarged depending on the type. So like we said, there are 4 types, right? So so depending on the type, the tonsil sizes depend on the type of the tonsillitis. So in a case of acute parenchymatous tonsillitis, it is enlarged much more. And in other cases, the follicular, the membranous types, so the enlargement is not to the significant level, but you have the other purulent materials and the membrane over the tonsil, which is present. Okay, so treatment. So when the patient comes to you and you are eliciting the signs, and now you have to also do some investigations, basic investigations. So that would be the ASO titer from a throat swab, and throat swab cultural sensitivity can be done. And after that, you see the organisms, and then you start the treatment for the patient. So first is basically the bed rest. The patient has to take a lot of rest and plenty of oral fluids and analgesics to subside his pain, because he has complaints of difficulty in swallowing and throat pain also he will complain. So here we have to put him on analgesics. Analgesics and antipyretics also can be used because the patient will have fever. So antimicrobial therapy. So usually it's the penicillin that is given for the patient. So in case of penicillin sensitivity, macrolides are given. So what can be the complication of an acute tonsillitis? So for an acute case, you treat the patient medically. So that is the most important thing. You treat the patient medically with oral antibiotics. You can also give oral antiseptics also. They can do gargle, povidone iodine mouth gargle can be done. Okay. And the complications of an acute tonsillitis. So what are the things that can happen in a case of acute tonsillitis? So the acute can progress into a chronic tonsillitis. So it can happen. And there's something called the peritonsillar abscess, which I already told you. So there is pus collection between the tonsillar capsule and the tonsillar bed in the loose areolar tissue region. So that can happen. So that's the peritonsillar abscess. And there is something called the parapharyngeal abscess that can happen. And cervical abscess, acute otitis media, rheumatic fever, and acute glomerulonephritis, and SABE, so subacute bacterial endocarditis. So these three, rheumatic fever, acute glomerulonephritis, SABE, subacute bacterial endocarditis, because it is also caused by the group B streptococci, beta hemolytic streptococci. So that's why you have this rheumatic fever and acute glomerulonephritis and subacute bacterial endocarditis. So the differential diagnosis. So we discussed about the membranous tonsils. So it just looked like a membrane, whitish membrane, which is present over the medial surface of the tonsil, and also it covers the pillars. So what are the differential diagnosis of membrane over the tonsil? So the differential diagnosis of membrane over the tonsil. So basically, the membranous tonsil. So there are other things which can cause membrane over the tonsil. So we have a set of 10 differential diagnosis for a membrane over the tonsil. And okay, the complications, usually the rheumatic fever, glomerulonephritis, and SABE, I told you, it's because of the hemolytic streptococci, which causes infection in the throat as well as in these conditions. So differential diagnosis. So first is the membranous tonsillitis, and the other one is the faucial diphtheria. The other one is the Vincent's angina, infectious mononucleosis, agranulocytosis, leukemia, traumatic ulcer, aphthous ulcer, malignancy. So in all these conditions, you can find membrane over the tonsil. So we have to rule out the cause for membrane over the tonsil. So, okay. So this is an important question which is asked in the undergraduate level of examinations. So differential diagnosis of membrane over the tonsil. Now moving on to the chronic tonsillitis. So chronic tonsillitis is a complication of an acute tonsillitis. Basically, something which is acute, due to repeated infection and inflammation, which progresses to a chronic stage. That's the chronic tonsillitis. So here, The etiology, which includes it's a complication of acute tonsillitis and subclinical infection of the tonsil, and chronic sinusitis or dental sepsis can lead to chronic tonsillitis. It mostly affects the children and young adults. So sinusitis, uh, because there's continuous postnasal drip, so the infection just drips down the oropharynx, so which can lead to chronic tonsillitis. The types of chronic tonsillitis. So there are three basic types of chronic tonsillitis. One is the chronic follicular tonsillitis. One is the chronic parenchymatous tonsillitis. One is the chronic fibrotic tonsillitis. So chronic follicular, like we discussed in the acute follicular, so you have follicles present on the medial surface, which is due to the presence of purulent material in the crypt opening. And chronic parenchymatous tonsillitis, here the tonsils are very much enlarged uniformly and may interfere with speech, deglutition, and respiration. Long-standing cases may develop pulmonary hypertension. So these are the symptoms that a chronic parenchymatous tonsillitis can lead to. So usually it's the thick speech. They say it like the patient cannot talk properly, and they have deglutition issues and respiration, and long-standing cases may lead to pulmonary hypertension. And the chronic fibrotic tonsillitis, the tonsil size is not enlarged, but still you have a inflammation and the infection of the tonsils. Tonsil size is not enlarged, it's fibrotic. Clinical features. So the clinical features, which includes recurrent attacks of sore throat. So the patient will complain of recurrent attacks of sore throat. Usually, they will have severe. So every month they will have attacks of sore throat. So that's a kind of feature that the chronic tonsillitis will present with, and chronic irritation in throat with cough, and halitosis, like I said, bad breath, and dysphagia, odynophagia, and thick speech. Okay. So signs. So tonsil may show varying degree of enlargement depending on the type. So tonsils, the size is enlarged. So basically, it's grade 1, 2, 3, 4. So it can enlarge depending on the type, severity of the infection and the inflammation. So it can enlarge to grade 1, 2, 3, and 4. And even more sign. So when you give some pressure on the anterior pillar, it expresses a frank pus or cheesy material mainly seen in fibrotic type, they say. Flushing of the anterior pillar compared to rest of the pharyngeal mucosa. So anterior pillar is congested. Enlargement of the jugulo-digastric node, but it's not tender. It's soft and non-tender. So the treatment, like we discussed already, so uh, you treat the patient with medical management. So bed rest, plenty of fluids, and antibiotics, analgesics, and local antiseptics can be used for conservative management. And if the case is severe, so according to, there is a criteria called the Paradise criteria for tonsillectomy. If there is a recurrent attacks of sore throats, like say for example, more than seven or more than 7 episodes per year, so it's one of the criteria to be included, that the patient can go for a tonsillectomy. Otherwise, 5 or more episodes in 2 consecutive years, the patient is can be taken up for tonsillectomy. Otherwise, 3 or more episodes of sore throat and recurrent attacks of sore throat for 3 consecutive years, you can opt the patient for tonsillectomy. Otherwise, continuous leave taken from absence from school because of this issue for more than 2 weeks, 3 weeks. So the patient can undergo tonsillectomy. So the complications of chronic tonsillitis. So it's basically the peritonsillar abscess, uh, parapharyngeal abscess, retropharyngeal abscess, intratonsillar abscess, tonsillar cyst, tonsillolith, and it could be a focus of infection for rheumatic fever and acute glomerulonephritis and SABE also, because it's basically by the hemolytic streptococci, which causes the chronic tonsillitis infection. So, which could be a focus of infection for all these conditions: rheumatic fever, acute glomerulonephritis. Okay. And like I said, the peritonsillar abscess, which is a complication of a acute tonsillitis as well as the chronic tonsillitis, is nothing but there is collection in the peritonsillar space. So just that I've put this picture to show there is only one-sided enlargement of the tonsil. So the other side appears normal, but here if you see, the left side is enlarged and it just pushes the uvula to one side. So you will find deviation of the uvula to the opposite side, and also there is enlargement of the tonsil on one side. So this is the peritonsillar abscess. So yeah, with that we can wind up this session. The other things to be discussed are the tonsillectomy. So that the surgery and surgical complications, surgical indications, surgical contraindications, that will discuss in a next video. So these are the this is the basic overview of a tonsillitis. Hope you all understood. Thank you.